Welcome back to the Critical Care Shock Lecture Series. More specifically, welcome back to the Shock Volume Series. During this session, we'll be covering Volume Part 3, that's Fluid Tolerance. Before moving forward, a bit of housekeeping. I have no relationship with industry, nor do I have any financial conflicts. Let's start off by going through some objectives and goals for today's session. We're going to discuss the relatively new concept of fluid tolerance. We'll briefly review clinical exam and hemodynamics. We'll spend some time on lung and cardiac ultrasound. And then lastly, we'll review the VExUS ultrasound protocol. A quick preamble before moving forward. This lecture is dominated by point-of-care ultrasound assessment. It's only my intention to shed some light on these various assessment tools. The how-to of POCUS, of point-of-care ultrasound, is beyond the scope and time constraints of this lecture. If you don't have POCUS training, get it. A quick flashback, and you'll recall in previous lectures, much of our job in the ICU, it's like a teeter-totter. It's about balance. Whether it's balancing oxygen delivery and oxygen consumption, or balancing fluid resuscitation. Our current challenge in our volume lecture series is balancing between optimizing organ perfusion and avoiding fluid overload. Interestingly, if you think of IV fluids as a drug or medication, they have a relatively narrow therapeutic window. Coming back to the big question of should I give volume? In Volume Part 2 lecture, we extensively covered the first two questions here. Is the patient hyperperfused and or in shock? And is the patient fluid responsive? For a quick recap, fluid responsiveness is a type of bedside test that affects the preload status of the heart. This allows the clinician to assess this action or this manipulation to determine if there's an increase in cardiac output. A positive fluid responder increases the probability that the fluid we give to the patient increases their stroke volume or cardiac output. However, it doesn't guarantee that the fluid administration will be safe. If you think about it, we inflict an action or intervention or manipulation. To make things simple here, we'll say this is just a fluid challenge. We give that fluid challenge and we load the right heart. Thus, we load the left heart. And under optimal conditions, we look for an increase in stroke volume or cardiac output, or maybe we look at a manipulation of the heart-lung interaction, i.e. pulse pressure variation, stroke volume variation, or maybe we look with echo and see the aortic VTI. However, it seems like we overlook what occurs in between. So we have these increased right heart pressures from administering volume from increasing and loading the right heart. We have backward increase in venous pressure. This can cause RV dysfunction, neurological dysfunction, liver and kidney dysfunction. In addition, there's increased hydrostatic pressure in the lungs, and this could cause pulmonary edema. But what tests or assessments do we have to understand this situation? And this is where the concept of fluid tolerance come in. So the third question is the patient fluid tolerant. So I'd like to preface this lecture by saying this is a relatively new paradigm. We don't have all the answers yet. The literature is just starting to build. We're definitely in the proof of concept stage. I'd like you to think of this content as adjunctive tools regarding your pre-existing knowledge on fluid responsiveness. In fact, the concept is so new that our operational definition was just recently developed from a position paper out of the Journal of Critical Care. Fluid tolerance is defined by the degree to which a patient can tolerate administration of fluids without causation of organ dysfunction. I'd like to walk through a few beliefs or concepts of fluid tolerance. First, it's important to point out that fluid tolerance and fluid overload are not the same thing. Fluid overload is defined by greater than 10% fluid accumulation in the body. In addition, fluid tolerance is something that you evaluate in real time, where fluid overload is something that is assessed post-resuscitation. It's probably incorrect to assume in all patients that fluid tolerance only occurs in fluid unresponsive patients. I think if I pause this lecture and had you conceptually ponder on fluid responsiveness and fluid tolerance, you would say that once we've determined that the patient is not a fluid responder, there's an elusive cushion, a gray area between the patient being a fluid non-responder and that patient becoming a fluid intolerant patient. This might hold true for a healthy patient, however, it's debatable in a critically ill patient. In addition, I think most of us defer to a binary decision model. The patient is not fluid responsive, this equals no fluid administration, and if the patient is determined to be a fluid responder, there's a reflexive impulse to administer fluid. So this binary decision model may leave us somewhat blind to the right heart and venous system. I feel that if I actually watched folks at bedside, I'd get a little different story. Most of us push and push fluid resuscitation until the patient no longer is fluid responsive. And at the same moment, we feel that the patient is fluid intolerant as well. So this situation acts as almost a de facto endpoint for fluid resuscitation. What's most likely more factual, especially in critically ill patients, is that there's a disconnect between fluid tolerance and fluid responsiveness. That is, there's a subset of patients that are determined to be fluid responsive, but they may not be fluid tolerant. Said in a simpler way, the patient may demonstrate fluid responsiveness by increasing their stroke volume or cardiac output by at least 10%. However, they may incur negative consequences of increased venous pressures related to organ dysfunction. And this situation is somewhat of a moving target. The patient's fluid responsiveness could shift to the left of the graphic, making the patient wanting or tolerating more fluid. These patients may have incurred an inflammatory response. They might have endothelial glycocalyx damage, decreased colloidosmotic pressure, or decreased lymphatic drainage. Likewise, the patient's fluid tolerance could shift to the right on whether the patient has pre-existing organ dysfunction, maybe RV dysfunction, hepatic dysfunction, renal dysfunction, maybe the patient has advanced age. And lastly, how about their current acute illness? They could have an impending or tedious respiratory situation where a little extra fluid might push them over into the fluid intolerant category. So what are some assessment tools that we may consider when looking at the fluid intolerant patient? Let's first talk about clinical exam. So with physical exam, we could look at JVD, lung sounds, heart sounds, and edema. And just a bit of commentary with this, breath sounds and heart sounds have an inherent risk for interpretation error. Edema can be very misleading. The patient could be exhibiting peripheral edema all while being intravascularly dry. I think JVD makes the most sense to me. So there's a reflection of elevated right heart pressures, and these increasing right heart pressures are transmitted back into the jugular vein, causing jugular venous distension. Next, how about symptomatology? Well, we have orthopnea, paroxysmal nocturnal dyspnea, dyspnea itself, and cough. All these can be non-specific. In fact, everything on this slide, even in heart failure literature, lacks sensitivity and specificity for fluid overload, more specifically fluid tolerance. They do, however, push you to further evaluate the patient for fluid tolerance. Now let's talk about a bit of hemodynamics. And we'll focus on CVP and pulmonary occlusion pressure. So as we've already discussed at length in previous lectures, these static filling pressures aren't useful in determining fluid responsiveness. However, do they play a role in understanding fluid tolerance? Maybe yes. Just to recap, CVP is a preload measure of the right heart. Pulmonary occlusion pressure is a preload measure of the left heart. And always important to remember that multiple variables go into preload, not just volume. Let's look more specifically at CVP, or right atrial pressure. Conceptually, this makes sense. There's a venous backup, a flow of pressure. This causes venous congestion, and one could surmise that this facilitates organ dysfunction. And they'd probably be right. The kidneys seem especially susceptible to this, considering it's an encapsulated retroperineal organ. There's little ability for the organ to distend, to swell, so the kidneys are vulnerable to this increase in venous backflow. I'm stressing this concept to foreshadow a monitoring technique that we'll discuss shortly. Increased venous pressure predisposes to acute kidney injury. This has been clearly proven in the heart failure literature, the cardiorenal literature, but there's also evidence to support this in the medical and the septic patient. We know that higher CVPs or abrupt increases in CVPs following fluid administration should throw a warning flag for fluid intolerance. Problem is, we really don't know the magic number. What's the cutoff number for the high CVP that indicates organ dysfunction? Here in this graph, you can see on the y-axis, this reflects the risk of new or persistent AKI, and on the x-axis, you can see the mean CVP. It appears that you have a steady rise in risk of AKI until about a CVP of 8. This then plateaus, and then after a CVP of 12, we're off to the races as far as risk for AKI. Pretty important to point out that this graph came from an adaptation of data from a retrospective observational study. And while we can recognize CVP as being a risk for new or persistent acute kidney injury, it may be too late. That is, once the CVP is that high, the organ dysfunction may have already occurred. The patient's already actively congested. This brings up timing of the elevated pressures and finding windows of opportunity before there's actual venous congestion. None of this is worth it if we can't find a signal as to when there's risk or venous strain. Organ congestion is just too late. Now let's move on to pulmonary occlusion pressure. Pulmonary occlusion pressure, or wedge pressure, can be used to identify postcapillary pulmonary hypertension and LV failure overload. Traditionally, one of the hemodynamic criteria for LV failure would be a pulmonary occlusion pressure greater than 18 millimeters of mercury. However, inflammatory processes can result in increased pulmonary capillary leak that is often much below 18 millimeters of mercury. So while I'm not trying to dispute the accuracy of an elevated pulmonary occlusion pressure, I am trying to say that once you've hit this critical threshold of 18 millimeters of mercury, you're probably way too late. So might there be earlier signals to identify patients that are fluid intolerant? Well, POCUS, point of care ultrasound, may end up being at least part of the answer. First, let's take a look at lung ultrasound. So lung ultrasound for the detection of pulmonary edema carries amazingly high sensitivity and specificity, much better than chest x-ray. The question is, can we use it as a marker of early fluid intolerance and a grading for extravascular lung water? So in the perfect world, it looks like this. The The patient's admitted with septic shock secondary to urinary origin. Your lung ultrasound assessment prior to administering fluid demonstrates A profile, A lines. After 2 liters of volume resuscitation, you repeat a lung ultrasound, and now it demonstrates type B lines. The significance here is that your patient changed from an A profile to a B profile secondary to fluid resuscitation. This indicates early subclinical interstitial syndrome, i.e. pulmonary edema / capillary leak. This is a useful tool, but there's inherent shortcomings to this as an isolated method to predict fluid intolerance, including heterogeneity of the disease processes, ultrasound competency, and level of ultrasound experience to discern different subtypes of B lines. So again, while this can be useful, the area under the curve, sensitivity, and specificity are suboptimal as an isolated test. So now let's take a look at cardiac ultrasound. And with that, we look at an approximation of cardiac contractility. So quantitative assessment is definitely possible for the critical care provider, but qualitative is more convenient, and literature tells us it suffices when taking care of a critically ill patient. Here we see an anterior 4-chamber view of the heart. We see a dilated left atrium. We see a dilated left ventricle. We see a severely reduced left ejection fraction. We won't say much about the right heart with the exception that there's a PA catheter coursing through the RA and RV. So while this assists in narrowing down the shock etiology, it doesn't necessarily guide your fluid resuscitation, at least not directly. Overall, it may lead you to a more conservative fluid resuscitation approach, but whether that's correct or not, we don't know. Assessing cardiac contractility is really the foundation of cardiac ultrasound. It's POCUS 101. There's some items that I'd like to point out though. There's a poor relationship between the cardiac filling and total vascular volume, i.e. this echo does not tell me anything about the patient's fluid status. Another item is looking at left ventricular ejection fraction. It really confers interaction between the ventricular function and arterial load. And what exactly do I mean by that? You could have a historically reduced left ejection fraction and then suffer a situation that you have a very low SVR, a low arterial load, and your ejection fraction may look increased. We need to be mindful of this when interpreting our echoes. We also need to remember that we're trying to understand the relationship between the cardiac filling and the stroke volume, and this is really in regards to the Frank-Starling curve. We need to be cognizant that a patient with a lower ejection fraction most likely will not benefit from the increased preload in relation to effect of increased stroke volume. And then lastly, assessing ejection fraction doesn't account for heart failure preserved ejection fraction / cardiac relaxation / lusitropy. To do that, we would have to increase our ultrasound knowledge to include diastology. Diastology is the understanding of the diastolic filling of the heart, the relaxation portion of the heart. If you think about it, a healthy heart appropriately relaxes and facilitates early ventricular filling during diastole, a suction effect, if you will, as the left ventricle relaxes and actively fills and suctions blood from the atrium. A sick heart is stiff, it's less relaxed, it doesn't appropriately passively fill, and unfortunately the atrium needs to overcome the pressure by actively filling the ventricle. I've always remembered this by the mantra of healthy hearts suck and sick hearts blow. Probably a more HR-friendly mantra would be that sick hearts push and healthy hearts pull. So how do we assess diastology with echo? So briefly, we're going to obtain a 4 anterior chamber view. We're going to turn on our pulse wave Doppler. We're going to put our gate right at the mitral valve inflow, and we're going to activate our pulse wave Doppler to measure mitral valve inflow velocity. In the graphic to the right, the upper spectrograph demonstrates E and A. E is the early diastolic flow velocity, and A is the atrial contraction. Next, we're going to use tissue Doppler. You can drop the tissue Doppler imaging gate at the lateral or septal annulus of the mitral valve. In this graphic, we're using the lateral annulus. You can actually measure muscle movement of the LV moving away from the probe during relaxation, and you're actually measuring the speed at which it relaxes. So a way to think about it, a healthy heart relaxes very fast, very quickly. A sick heart doesn't. And this is depicted in the lower portion of the spectrograph with lowercase e prime, lowercase a prime. An oversimplified explanation would be to take a look at the mitral valve flow velocity. Here you see E, which is the early diastolic flow velocity, and then you see A, which is the atrial contraction. Here in a normal patient, a healthy heart, you can understand that the early diastolic flow velocity, the relaxation, the suction effect is much stronger than that of the atrial contraction. Now let's take a look at a sick heart. Here you can see the E is much lower than the A. This is called reversal of EA. And this is indicating there's poor relaxation, there's poor suction of the ventricle, and the atrium has to work overload to get that blood from the atrium to the ventricle. Now my experience with diastology at bedside is that of pattern recognition. However, technically you can and probably should measure these velocities. With that said, some experts advocate for interpretation of E prime or EA index or E/E prime as a non-invasive means for left atrial pressure. And you can think of a left atrial atrial pressure as the pulmonary occlusion pressure on a PA catheter. The index that I'm most familiar with is the E and E prime index. Loosely, if your E/E prime index is less than 8, you have a normal left atrial pressure. If your index is greater than 15, you have an elevated left atrial pressure. The problem is if you have an index between 9 and 14, that's in your gray zone and it's indeterminate. And while having data like this is informative, it's just like a pulmonary occlusion pressure. There's inflammatory processes at hand that can result in increased pulmonary capillary leak prior to the recognition of these standard left atrial pressure cutoffs. And like many tests, there's inherent limitations. Lastly, correlations between these indices and a pulmonary occlusion pressure aren't the same throughout all populations and disease processes. Another qualitative assessment I'd like to throw out there before moving forward is RV failure. The cine loop to the left demonstrates a parasternal short access view. There's a large dilated RV. There's an underfilled hypercontractile LV. There's a clear interventricular septum flattening. The LV is shaped like a D as opposed to a donut. This is referred to as the D sign. The cine loop to the right demonstrates a subcostal view of the IVC. The IVC is plethoric, with its diameter measuring greater than 2 centimeters. In addition, if you look closely, you'll see presence of ultrasound smoke in the IVC. This indicates venous blood stasis. Tying these two echo loops together, this patient most likely is fluid intolerant. In fact, there's a good chance administering fluid to this patient will worsen their RV failure. I strongly recommend not giving fluid to this patient, but since it's a fluid tolerant lecture, the correct comment from me would be that further investigation is needed prior to making that decision. We'll talk about the additional POCUS investigations very shortly in the upcoming slides. Before that, let's move on to the infamous IVC. So we've discussed in past lectures that IVC isn't the best standalone assessment tool for fluid responsiveness, but can we use it for fluid tolerance? Well, maybe. With that, there needs to be some assumptions put forth. 1, IVC correlates with CVP to an extent. 2, high CVPs are bad. And 3, unfortunately, we don't know the high-end cutoffs for CVP. The bad thing is, an IVC greater than 2 centimeters isn't very reliable at predicting a high CVP, surprisingly. In fact, IV dilatation alone has poor diagnostic performance to detect venous congestion and to assess risk for AKI. However, an IVC less than 2 centimeters is a strong predictor of a low CVP system. It actually carries a positive predictive value of 87%. So we probably can use IVC to exclude a high CVP, to exclude venous congestion. Now let's move on to some Doppler assessment modalities that may help us determine fluid tolerance. With that, we're going to start discussing the VExUS protocol. This is venous excess ultrasound grading system. And first, we're going to take a look at the liver. We're going to take a look at the hepatic veins. So first, you're going to obtain an image of the hepatic veins in 2D echo. Then you're going to apply color flow Doppler, and you'll identify the hepatic veins by blue color waveform. And this is because the blood flow is moving away from the probe. We can take a look at this graphic to further understand the flow. As you can see your probe here, the hepatic veins are carrying blood from the liver into the IVC, so the blood is moving away from the probe. Once we've identified the hepatic veins, we're going to go ahead and activate pulse wave Doppler. We're going to place the pulse wave Doppler gate on the hepatic veins right before it enters the IVC. We're then going to activate our pulse wave Doppler, and we're going to go ahead and get our spectrogram that we see here. One thing to point out is that hepatic vein Dopplers are strongly influenced by tricuspid regurg, and this may influence our interpretation. Next, we're going to turn our attention to the portal vein. Once again, we're going to obtain our image, this time of the portal vein via 2D echo. We're then going to activate our color flow Doppler. We're going to identify the red. It's red because the flow is moving towards the probe. Once again, this graphic should help us understand this. The portal system, the portal vein, is pulling blood from the body into the liver. So blood is actually coming towards the probe in this situation. Once we've identified the portal vein, we're going to activate pulse wave Doppler. We're going to drop our gate on the portal vein. We're going to activate our pulse wave Doppler, and we're going to have this spectrogram demonstrated as seen here. Next, we're going to take a look at intrarenal Doppler flow. Here you can see that we've identified the portal vessels. We've dropped our pulse wave Doppler gate. We've activated pulse wave Doppler, and here is our spectrogram. Most interesting, these vessels are so tiny and close together that you actually obtain arterial and venous velocities in the same spectrogram as you can see here below. For the purposes of fluid tolerance, we're only taking a look at the venous spectrogram. This unfortunately is the most difficult Doppler modality in this protocol. It definitely takes additional training and it opens risk for errors. There's tiny vessels to target with pulse wave Doppler, all while the patient is breathing. So now let's tie together this protocol, this grading system. So before moving forward, again, as stated during the intro of this lecture, teaching the fine details of POCUS or the VExUS protocol are outside the scope of this lecture. I'm going to merely walk you through the process and logistics of the VExUS protocol. Image acquisition and interpretation definitely require additional training. So here you have an IVC that's less than 2 centimeters. You can stop. You're a grade 0. We know that IVC less than 2 centimeters is associated with a low CVP and a low risk for venous congestion. Now, during a VExUS grade 1 clinical situation, you would see an IVC that's greater than 2 centimeters, and the patient demonstrates either normal Doppler patterns or mildly abnormal hepatic, portal, and/or intrarenal vessel Dopplers. This is a patient that you could define as being at risk for early congestion. A VExUS grade 2 finding would be consistent with active mild congestion. This would be defined as an IVC greater than 2 centimeters and severe abnormalities in at least one venous Doppler of either the hepatic, portal, or intrarenal veins. And then lastly, a patient with severe congestion or a VExUS grade 3 finding would have a dilated IVC and severe abnormalities in multiple venous Dopplers of the hepatic, portal, and/or intrarenal veins. A patient with a grade 3 VExUS profile incurs a hazard ratio of 2.82 for acute kidney injury. That's nearly 3 times the risk of AKI. So where does this bring us? The concept of fluid tolerance is relatively new. We need to continually search for evidence of fluid intolerance and venous congestion prior to administering fluids. We need to focus our efforts on doing no harm in relation to fluid resuscitation. In closing, I need to remind you that this is a proof of concept paradigm. However, the VExUS ultrasound protocol and grading system may be the best tool in our toolbox at this time when it comes to fluid tolerance assessment. Thank you for your attendance and attention. If you have any questions, please feel free to email me at the address listed. With the knowledge that you've attained from Volume Part 1, Part 2, and Part 3, you can now more adequately deliver safe and efficient care when it comes to fluid resuscitation during shock.